Hello, everyone, and welcome to another installation of our SABCS conversations. We continue even after SABCS. I have Dr. Vidal here. Welcome to our show, I'll call it.
Our show. Yeah.
Yes.
Thanks
Dr. Vidal, absolutely. If you can introduce yourself, that would be wonderful, and share us a little bit about your background.
Yes, my name is Gregory Vidal. I am a breast medical oncologist at the West Cancer Center and Research Institute in Memphis, Tennessee. I'm originally from the Caribbean, so I'm an offshoot living in the US now. As an occupation, I only do breast cancer. I'm a breast medical oncologist. I also spend a significant amount of my time in research. I direct the clinical research program at West. I'm also involved with One Oncology, which is a group of community oncology practices that have the former unit that do research and other clinical activities. I chair their breast group. I'm involved with ASCO, the ASCO Research Committee. I've been on the Advisory Guideline Committee. And so I'm all involved with breast cancer and breast cancer research.
Excellent. Well, we're so happy that you're here with us today. I have some questions that we'd love to ask you, and this could be, a roundtable discussion. But one of our first questions is, in your opinion, what are the most important updates that came out of SABCS, and how do you think they'll impact triple negative breast cancer?
So in general or in triple negative? So triple negative wasn't very well represented at
It wasn't. It was not our year. It was not our year. It was the year of HER2, right?
It was the year of HER2. There are some ER positive trials too. The one trial that comes to mind is the addition of platinum to early breast cancer. What we talk about the anthracycline with chemotherapy, platinum like carboplatin, which was the regimen. There are a few other trials that have shown that there is potentially benefit. Early on, it was maybe there is, because there was one trial that showed there was benefit, another that did not. The brightness study, I think, did confirm that the addition of carboplatin to standard chemotherapy was beneficial, had clinical benefit. And then there was another trial that was presented at San Antonio, and that also confirmed that. So essentially, if you have late enough stage, more aggressive type of triple negative breast cancer, that the addition of platinum to chemotherapy may be something that your physician should consider.
And that's what I took, Dr. Vidal, after THC failed me. That was what Dr. Reagan recommended when my breast cancer came back. And that was 11 years ago, 10 years ago. And so back then it was experimental for TNBC. So I wasn't in a trial, but it was an experimental drug. And so it was interesting when I saw that data at SABCS to see that, wow, they just did a trial for that, because that's what saved my life. Yeah.
So it's been ongoing for a while. There was a CLGB trial. There was a GEPAR trial. There was I-SPY trial, all added, and then there was the brightness that added carboplatin. I think GEPAR was positive, CLGB was negative, I-SPY was, so the data was all over the place. So I utilized it very early on because I recognized for patients with more aggressive, larger tumors, based on all of the studies and putting them together, that those patients did get some benefit. There was reduction in tumor size response, pathologic complete response benefit. The question was whether or not it prevented recurrence over not addition. The GEPAR trial did show that it did, but then the brightness trial, which was randomized, phase 3, did confirm that there is benefit. Now the Merck 522 regimen, which I don't know if you guys are familiar with that, essentially it's now the standard for larger tumors where you add immunotherapy to chemotherapy. That regimen had carboplatin built into it. So it sort of made carboplatin standard now. So we added to the Taxol arm of the chemotherapy.
Okay.
pembrolizumab.
And what
Right.
you're saying is really resonating with me in a bunch of ways. First, the fact, Ricky, that you talked about having been saved by a drug that was experimental at the time, then, studied in various clinical trials in different ways, and now is being used to treat patients as a, part of the standard of care. So that just, it highlights what we've been talking about, both in, in terms of representation and just in general, clinical trials, and the work that you've been doing, Ricky. And
And
especially,
Dr. Val too, he's like
Yes.
rocking on clinical trial representation.
which is so important. Can you talk a little bit about that and the importance of representation in clinical trials and just clinical trials in general for the TNBC population? Because fear of recurrence is so huge
We don't
in
have
the
a drug.
population, and sometimes a clinical trial might be a great option to be monitored throughout.
Yes, so it's an area of interest and research for me. A few points that you made. One, I'll take the last one, the importance of clinical trial as a treatment option for patients. In triple negative, where really for most part, for many years, the only option had been chemotherapy. We are looking at more targeted therapeutic approaches, and with chemotherapy and its toxicity, many times the best option for therapy is a clinical trial. It gives you the option of getting those innovative therapies before it is actually FDA approved. Now, the other question about representation in clinical trial is a big deal. The fact is, most patients, most trials don't really have enough patients of color in their trial such that you could really make true evaluation of whether or not those trials or those drugs really benefit that particular population. So our efforts in Memphis, we've fortunately for the West Clinic, where I am, we've actually done very well in terms of recruiting patients of color on studies. We've averaged somewhere between 25 and 30% over the
Which
years.
is amazing. That is unheard of. You know that.
National average is like 5%.
Yeah.
So we've been doing very, very well, and we've been making efforts, and we've done a lot of things from, making sure that patients who don't have insurance can still get on trial by absorbing some of those costs that would otherwise you would need insurance to cover. And we do a lot of things like transportation, also just spending time with patients and making sure that they understand. A lot of the lack of representation has to do with patients not really understanding and having a misunderstanding of what a trial is and what they're going to get. We don't have trials now where you get a lower standard of care, right? Trials are either standard of care or, so patients, we don't give you an option where you get worse than what you normally get.
Right.
No sugar pill.
Exactly.
There's no sugar pill in cancer research. We can't say that enough,
We can't say that enough. And so just really explaining and taking the time to sit with patients and say, okay, what are your concerns about not participating in the study? And then, I always say it is always your choice. But I really just want to know, what are your concerns? And see if I can explain to you or clarify this a little bit so you have a better understanding. And we've been pretty successful at that. A lot of patients have the concerns about, being a guinea pig and having to explain that. And also, family members.
You go home to mama and she's like, no, right?
Oh, no. And so I have to reach out to those family members and say, well, tell me what's your concern, because this is the best option for her at this point. And one of the other things that I also say is, and I get the God thing too from a lot of my patients, that I'm leaving it up to God, and He will take care of me. And I often say, well, I think he's trying to help you by bringing you in my presence.
Right.
You know, so let's not ignore that. He
Right.
gave
He
me
said
the
you can.
capabilities to help you. I know he's brought you here, so can you at least listen to me and then make your decision? So we have those conversations, but you have to take the time with a lot of patients, but not only patients of color, but you know, we see that in Caucasian patients. Patients, we are now in Memphis seeing more and more Hispanic patients who don't speak English, so we have to take the time and get the right interpreters so that they make sure that everybody understands what's going on.
But
the
you're
barrier
an
to-
anomaly. You're an anomaly because no doctors are spending time like that, and that's what it takes. I think also, you know, you said so many awesome things, but it's really just overcoming the fear of the unknown. You know, when you think about trials, and frankly, when I meet a Black woman who's under 40 and has TNBC, the best treatment option is a clinical trial for them right now. That's because we don't have enough drugs for TNBC, and the best science is available to them. That's what they need to be doing, you know?
Yeah, we you know, one of the things that patients don't really understand too is that we cure most breast cancer, even triple negative. Most breast cancer patients who come with triple negative breast cancer, we cure them.
Say
It
that
just-
again, say that again, say that again. Yeah, say that again.
Into
Most-
the camera.
Most patients who present with triple negative breast cancer are cured.
Thank
All
you.
right, they're cured. It happens that triple negative is a little bit more aggressive, so they tend to have a higher rate of recurrence as compared to the other one, but we cure most of them. And if you follow the treatment paradigm, the recipe, then we can get you to that cure. Many times it involves a clinical trial. Now we have immunotherapy as part of the treatment. Immunotherapy now has increased the chance that when I give you chemotherapy, we kill all the tumor in the breast, what we call pathologic complete response. We participated in a trial. We put almost 10 patients on this study. And a lot of them were patients of color. If we hadn't participated in the study, we wouldn't have known that this is a benefit.
Right.
You know, and it's controlling the disease much more. So yeah, putting in a plug for clinical trial, putting in a plug for knowing your breast.
Yes.
Again, cancer is cured because we find it early. So the sooner you can get to know what you have and get the treatment, the better it is. And also really advocating for yourself.
Yeah.
If you are with a physician that you think is not listening to you, and or you don't quite understand, ask questions. And it is totally fine to get a second opinion.
Right.
It wouldn't hurt my feelings. If it's hurting the feelings of your physician,
They need to go.
Yeah.
first, you should think twice. But
Right.
there's no reason your physician should get offended by you going to get a second.
Absolutely.
Dr. Vidal, I'm curious, you know, we loved hearing, you know, obviously that most TNBC cases can be cured. I'd like to address the metastatic community for a moment. Have you heard about any new targeted therapies specifically for metastatic triple negative breast cancer? And is there any new clinical trial data that you can share?
Yeah, so there's a lot of ongoing clinical trials. Most of those and most of the positive news are in the other tumor types, but there are some news coming out of triple negative. For example, the new ADC, Enhertu, also known as TDXD, which was studied in a population that is what we call HER2 low. So if you're ER negative and HER2 low, traditionally you're triple negative, so you're in that population. Although it was a small subset of patients on that trial, but that drug also showed that in a later stage patient, that those patients had better control and lived longer, although a small subset. So I think in triple negative, the ADCs, the antibody drug conjugate, where you have an antibody almost like a smart bomb that goes only to the cancer cells and carries with it chemotherapy. So sacituzumab is one of those that has been shown to actually not only control, but make patients live longer.
Trodelvy, sacituzumab.
Trodelvy is the, yes. So those drugs are on the market. Immunotherapy in that population. And there are lots of, we're also studying now more targeted approach based on mutation. PARP inhibitor for BRCA mutation for patients with not necessarily BRCA, but also alteration of that pathway. PI3 kinase inhibitors are being studied in triple negative. Other immunotherapies are also being studied and combinations of those. So there are lots that are going on, and a lot of them have shown really good early responses. There's another drug called Dato-DXd, which essentially is the same active chemotherapy as TDXd or Enhertu, but with a different antibody. That's also showing really good early responses.
What's the brand name for that drug?
Doesn't have a brand name yet. It's still in clinical trial. There's HER3. So we've talked about ERB2, which is trastuzumab type. There's another protein within that family called HER3. There has been data shown at San Antonio, I think updated at San Antonio, but first seen at ASCO last year, where patients who have overexpression of that particular protein, who themselves are traditionally triple negative, there's an antibody drug conjugate that has shown really good responses. And we may be just changing how we traditionally think of cancers. Now we have a HER2 low, which could be traditionally a triple negative. We may have a HER3 high, which could be traditionally triple negative. So again, putting in a plug for molecular profiling of your tumor. It is so important. I don't think you should have a metastatic patient being treated who hasn't had a molecular profile.
Genomic testing.
Not only genomic testing, but molecular testing on the tumor, because it can change what we have. I recently wrote up with with two of my medical students, a case report on a triple negative patient. Very, very interesting. I'll just tell you the short story. She was treated by one of my partners, got diagnosed in 2008, I think.
Oh, wow.
And recurred in 2010 with metastatic triple negative, essentially refused any treatment because she said chemotherapy didn't work, refused treatment, went to do alternative therapy. Lucky for her, because the average triple negative patient have a survival somewhere in the 18-month region. Her tumor just grew very slowly, and she came to see me in 2021 because the tumor picked up in terms of its progress, and she felt like the other physician wasn't doing everything. So we did a molecular profile on her, like, okay, let's do this. Turns out she had an NTRK fusion. And if you don't know, NTRK fusion is a fusion that causes tumorigenesis across tumor type. There's a drug, 2 drugs specifically approved for those type of fusion, and it's not based on breast cancer tumor type. It's based on having the mutation. We gave this woman this drug we started in November. I had a scan of her last month, and there's no disease. It's all melted.
Wow. Oh my God.
So in addition to genetic testing, molecular tumor testing for metastatic patients is a takeaway. Wow.
It's like really, it's like customized treatment, basically.
Exactly. Her case was interesting, and not everybody may get that robust a response, but what it shows is there are treatment options available outside of what we traditionally think as triple negative treatment if we are able to know more about the tumor.
Wow. And she had it for like over 10 years. God bless her.
Yes,
God didn't want, yeah, she was meant to be here, man, right?
That's
I
incredible.
I agree.
That's
Yeah.
really incredible.
God brought you to her. Wow.
You know, the next question is such a good jumping off point. So obviously for the triple negative breast cancer community, fear of recurrence is very, very real. And many of us that are, done with treatment, but maybe not quite at the 5-year mark, are interested in participating in trials to monitor their progress. Do these trials exist?
There are not many of those that exist, unfortunately, in the patients who've already had treatment and are in what we call the adjuvant setting. A lot of the trials are more about quality of life, side effect management, a lot of those trials there. We now have trials that we participate in that looks at what we call minimal residual disease using circulating tumor DNA to try to predict early recurrence. So what that means, to simplify that, each one of your cells in your body sends part of its DNA into circulation while it's repairing all the time. So the DNA of the tumor, if you can isolate or get the fingerprint through the DNA and mutation analysis of your tumor, then you can look in the blood to see if you can detect those pieces of DNA in the blood. And if you have 0, it means that, okay, there isn't a cancer cell producing them. But if you never had it, and now all of a sudden you're detecting it, it means that, hold on, there must be a cell somewhere in the body producing it. And it can potentially give us an early view into recurrence, such that we probably can change the trajectory of this disease. Right now, I do have patients asking me to do CT scans all the time, and I say to them in the curative setting, and it's not part of guideline recommendation. I say to them, I know you want CT scan, but do you know that a CT scan is not going to change your outcome? Because if I find it on CT scan outside of the breast, it's already too late. It's metastatic.
Wow. Right.
So CT scan is only telling me that you're stage 4.
Validated.
It doesn't change your trajectory.
Right.
A test like that, potentially, if we can find it very, very early where we haven't yet seen it on CT scan, we could potentially change the trajectory, starting medication, changing medication. And those are sort of trials that are being developed in that setting, Melissa. And there are lots of companies looking at that.
Amazing.
Amazing, right? Wow.
It
So
really
the blood
is.
tests, I mean, as you could tell from Melissa reading off some of the questions, one of the things that we did is we reached out to our community and we asked them what their questions were specifically. And the question of this blood test to determine recurrence kept coming up.
Right.
So I know it's being tested. When do you think something like that would be ready for prime time, as they say?
So ready for prime time and being available are sort of two different ones. So there is a test right now that has FDA approval that your physician could potentially order and get it paid for. The issue with it is it lacks full validation.
Wow.
Okay, to see if it really fully impacts your survival, and those are ongoing. I've used it in some, I have it in trial here. So if we're going to use it, we use it a patient on trial. I've used it in some clinical settings, mainly so one scenario is a patient I had who had a large tumor, did therapy, still had significant disease, the risk of recurrence is really high, and she decided she doesn't want to take any further therapy, which is the recommendation. And so I started following that, and I said, I do think you need it, but at least can I run those tests to see if your DNA is now coming up, and maybe that can then prompt you to say, let's do something.
Yeah.
Fortunately, it did come up, and she said she still didn't want to do anything, despite negative CT, and now she's metastatic, and it's changed So I've used it rarely, but it is available to for ordering, but the validation is not fully there.
Understood. Okay.
Wow.
You know, I think to round this little conversation, we could talk. You're such a wealth of knowledge, Dr. Vidal, really, and it's my first time actually meeting you on Zoom. You know, that's how we meet people these days. But really, we hope to speak with you again. I feel like we can. This is a conversation that we'd love to continue. But in the meantime, to leave our viewers with some good homework assignment and takeaways, are there any new lifestyle interventions that have been proven to prevent recurrence, and what are they? Like maybe eating chocolate.
Oh.
Ice cream, does ice cream?
Yes, Ricky's ice cream diet, I highly recommend.
Ricky's diet of ice cream and dancing. That's it.
The data there is very lacking. And it's lacking for a few reasons. One, it's difficult to study because of many other confounding factors. It's going to be large over long periods of time. I think just to sort of summarize my understanding of what there is that healthy diet, being healthy, exercise help, diet rich in more plant-based diet rather than animal-based diet helps, and fat, lowering your body's fat composition. We do know that fat can produce some estradiol, and there is some data to suggest that patients who are obese tend to have higher recurrences, more resistant to type of endocrine therapies. But I would say ultimately anything that sort of boosts your immune system. We know that the immune system is an important advocate and fighter of disease. We have immunotherapy that all it does, immunotherapy itself is not directly fighting the cancer. All it does is it boosts your immune system to help your immune system. So we know your immune system can do it. So any sort of habit that boosts your immune system is one that I would say you should probably participate in, but don't go overboard. I have cancer patients who don't want to eat anything with sugar in it. I say, your body, that's your main source of energy for your normal self also. So when you starve your entire body of glucose, you not only starve the cancer cells, but you starve your normal cells. And many times you become too weak such that you can't get the therapy that you need. So everything in moderate.
Right. So I was going to say, no, it's not necessary to go to an extreme on either side.
Eat the chocolate, Melissa.
Eat the chocolate is what I'm saying. That's our next campaign.
That's what we heard. That's what we heard.
Eat the chocolate. Well, Ricky, Haley, did you have any other questions for Dr. Vidal before we concluded?
This is so great.
This
So
was
great. So great.
I know you really helped us, kind of shed light on some of the thoughts we were having, and I really appreciate that. And I love the story about that was a big takeaway for me, the molecular testing, because that's not something that was on my radar to that degree before. I mean, hearing a story like that and seeing how testing like that can change the course of someone's treatment, that's huge.
Definitely. Highly recommended.
That's great. We should put that on our list of things to ask the doctor, add that to our list. We have this list of, telling people what to ask. So add that to it for sure.
Amazing. Well, thank you so much, Dr. Vidal. This has been such a wonderful addition to our SABCS lineup, and we can't wait to share this with everyone who's listening.
Appreciate it, and thanks for inviting me.
Thanks so much. We know you're busy saving lives, so we appreciate your time.
Appreciate it. Thank you. Have a good day.
Take care. Bye.
Okay. Bye.